Good morning, everyone. I am Reverend Domanic Smith, and this is Pastoral Outreach Coordinator for Population Health at LifeBridge Health. And this is Pam Phillips, RN Health Navigator at Carroll Hospital, a LifeBridge Health Center, right? Amen. You can have the next slide, please. For nearly 150 years, Sinai Hospital of Baltimore has been a Jewish-sponsored healthcare organization providing care for all people. Today, the legacy continues with the mission to provide quality patient care, teaching, and research. We value innovation, compassion, accountability, respect, and teamwork. We are caring for our communities together, meaning we work together to care for one another. The mission, LifeBridge Health and our affiliates, as you see here, are many, and they continue to grow on a daily basis. You see Sinai, you see Northwest, you see Carroll, you see Levendale, you see Seasons, Future Care, Ambulance, et cetera, and we're growing daily. I didn't know I had this ability. Thank you. This is designing of how the congregant will be identified. This is a Maryland Faith Community Health Network ID card that simply asks for the name of the participant, the congregation, and we're going to ask the congregation's address and the best contact number and the ID number so that when the person comes into the hospital, they can tell the individual who's helping them that I am a part of the Maryland Faith Community Health Network. One other thing, there's a confidentiality agreement in our folders. Does everyone have that? If we can take a minute to sign that. Oh, it's in the registration? Okay. Did everyone sign that, complete that? Okay. Responsibilities for LifeBridge Health and the liaison. For LifeBridge Health, we will connect the liaison and patient once patient is admitted and they request participation in the program. We will provide assistance and link patients with their faith community liaison. And that's after meeting with the patient and asking them if we want them to notify their liaison. And we will not be telling the liaison why the patient or the congregant is in the hospital. And we will be available to respond to questions from the liaison. The liaison, we want you to be prayerful and supportive. We have an at-home plan that we would like for you to complete, provided by the Maryland Faith Community Health Network with the patient and hospital staff prior to the patient's departure from the hospital. And the reason why we're asking that, as Stephanie talked about a few moments ago, if there are some needs that the patient may need once they return home to help them in their healing well, that would be identified before they are home. Thirdly, we would deploy appropriate congregational resources on behalf of the patient while being sensitive to the patient's privacy, and we asking the liaisons to be proactive. And what we mean by being proactive, if you see something that's not doing well with the patient or the congregant, and you may want to help, you may give myself or Pam Phillips a call, and my information will be listed that we can help them with some things that they may need additional help with or health care with. Pam?
So I'm going to talk a little bit about some of the things that you're going to run into at the hospital. So when you go to the hospital, whichever one it is, we want you to go to the information desk upon arriving to the hospital. We want you then to confirm the location of the patient or the congregant and learn, sometimes they're able to tell you if there's any precautions you have to follow. I am going to go over some of the precautions, but I don't want this to scare you. It's just information for you and an opportunity for you to have the knowledge. If you go to a patient's room and there's some signage on the door, just please read it. And we want you to follow the directions that the people give to you. All the institutions are very large, and so you do get lost. And if you're not sure, common sense, if you can't find something, then you just ask somebody in the hall where to go. If they tell you there's a swimming pool, there's not. So what kinds of precautions you might have to follow? So the next 3 slides, I'm just showing you what might be on a door. These are airborne precautions, and they're required to protect you against the airborne transmission of infectious agents. Diseases requiring airborne precautions include, but are not limited to, measles, severe acute respiratory syndrome or SARS, varicella, which is the chickenpox, and Mycobacterium tuberculosis. Those all sound very scary, and if you see this sign on the door, you do not have to enter. The next one that you might see is droplet precautions. And these apply to clients known or suspected to be infected with any pathogens that can be transmitted by droplets. Droplet transmission involves contact with the nose, the mouth, mucous membranes, or conjunctivae of a susceptible person. And there's a separate sign that says droplet precautions also. The next one is contact, which you're probably most familiar with. These are procedures that reduce the risk of spreading infections through direct or indirect contact. Same thing when you go to the grocery store. They have the little wipes that you can pull off and wipe off the handles of the grocery cart. So transmission occurs with physical contact of the infected patient or handling of a contaminated object in the infected patient's room. It doesn't just have to be in the room. It can be doorknobs. It can be anything that you touch, countertops, desks, and chairs. Masks, gowns, and gloves, as well as standard precautions, must be used. So again, just read the signs that are posted on the patient's room. We assume everybody has something, so standard precautions is just something that all hospital associates are just inherent. We wash our hands for everything. Same thing they teach the kindergartners, wash your hands. You as a liaison must sanitize your hands. You must do that after you touch things that other people have touched. Again, countertops, desks, chairs, doorknobs. Anytime that your hands feel dirty, they most likely are. After you handle money, when you enter a patient's room and when you leave the patient's room. Many times when you walk inside the door, right to the right-hand side of the door, there's a hand sanitizer. It might be one with a knob that you pull like this, or it might be foam. Put it on your hands, and you'll see the staff wash their hands as they enter into the room. Get in the habit of doing that if you're visiting anybody in the hospital. Of course, before and after you eat, you should wash your hands, after you use the bathroom, after you cough or sneeze, and before and after caring for a sick person. These are emergency response codes. There's not a test at the end. This is just for your knowledge, because whenever you're visiting anybody, whether it's your own family member or you're working as a liaison, these are some of the things that you might hear. Code yellow is an emergency or a disaster. We just had a code yellow with the blizzard. If you have no electric in the hospital, those are things that the staff are aware of, that they have to work things a little bit differently than they normally do. A code red, of course, is a fire. A code blue is a cardiac respiratory arrest. A code purple says security-only response, but if there could be a weapon involved. A code gold is a bomb threat. Code orange is a hazardous material spill. A code pink is infant or child abduction. A code green is a combative person. And code gray is elopement. Sounds very scary, doesn't it? But there are some things that you can do to help. If you hear a code pink, a child has been abducted in the hospital. What can you do as a visitor? Eyes and ears. If you see something, say something. That's all you have to do. We're not expecting you to follow all the rules that we have. But if you see something, just like we're all taught now, unfortunately, if you see something that just doesn't seem right, it most likely is not. So just let somebody at the hospital know. A code green could happen on the floor that you're visiting. If it's a code green, you hear a ruckus in the hall, Don't be a gopher and stick your head out to see what's happening. Just keep yourself in the room until it's all clear. Or if you see something going on in the hallway or disruption, just turn around and walk the other way. How do you get assistance for a patient? So, of course, if you're in visiting with somebody and you see that they need some help, there's a call bell most likely on the bed or on a cord. You push that button. You can always yell for help. That works very well. I've done that numerous times. People respond to yelling because it's not something that you normally hear in the hospital. And if you're on your way out and you want to let somebody know something, find a staff person, look them in the eye, tell them what's going on, and make sure that they respond to the patient. I'll let Domanic talk about HIPAA.
HIPAA is Health Insurance Portability and Accountability Act. It's a federal law. Patient protected health information is any identifiable information combined with health information such that the identity of the person would be known. HIPAA is the electronic format of HIPAA. Examples of protected health information is your name, address, date of birth, diagnosis, medications, insurance information, Social Security or medical record number, discussions between patient and provider, and notes written by providers and other staff. Okay, so we're all a part of the faith community, right? And we serve our God. And we want to be proactive in helping one another. We're not giving you an invitation to be nosy. Y'all know what I'm talking about? Oh, okay, I'm not the only church-going person here, right? We are not given the invitation to go through people's files and take it and go home and call and say, well, Sister so-and-so's in the hospital. No wonder she's been looking frail for the last 2 weeks because of X, Y, and Z. That's not our cause. Our cause is to help and provide better health with our members while we're working together to provide excellent health care. HIPAA, privacy, dealing with common issues. For example, conversations in public places. Be mindful of your surroundings when you're discussing patient information. Such discussions are not appropriate in the cafeteria or the elevator or simply walking down the hall. Tracking boards or whiteboards. These are communication tools and should include the minimum amount of information. Sign-in sheets, which are usually in offices or clinic setting, are permissible, but should only include patient name, no date of birth, no diagnosis, or social security number. Telephone calls. If someone calls to ask about a patient, to ascertain their relationship, try to ascertain their relationship before disclosing information. If the patient is able to ask their permission, allow them to speak to the caller themselves. Discussion in semi-private rooms is real tricky, always difficult. Some strategies to use is to pull the curtains, use as low a voice as possible to be able to be heard, and move the patient to a private area, which you would hit the call bell and ask for help. And if the patient says, and asks for their permission, if the patient says no, either ask the visitors to leave or to come back later. Because, people have visitors, and sometimes we come in and want to start talking their information in front of the visitors, and we need to ask their permission first. Computer access. We are given computer access, and that's for us according to our role and responsibility, and we do not share our computer access with one another. Social media. Please don't post anything on social media that you learn by way of LifeBridge Health from an individual who may be in the hospital. You know how we say, pray for sister so-and-so? She's really going through, or brother so-and-so. That can open a whole can of worms, and we can sometimes make a person diagnosis worse than what it is. We sometimes start out with good intentions, but we have to respect individuals' privacy. Nowadays, everybody has access to social media, and if they want to broadcast what's going on with them, allow them to do it. It is not our responsibility to do that. Paper records should be treated the same way as electronic records. And cheat sheets, many of a staff carry around a list of patients and reports that we're going to be seeing throughout the day, and we write our own notes on them. And so we have to keep them close to us to make sure that we don't drop them along the way. One other thing I wanted to touch on briefly, and Pam will come back. You know how we have the prayer ministry at the church or the congregation? And we have the bulletin, and we list the people's name in the bulletin, which I personally have real issues in it, because I may not want everybody to know my address. But we do that, and that's not always the right thing to do. Because a part of healing also comes with, I think Dr. Foster really talked about it, peace and resting. And we have to provide that space for people to get those things. I know our intentions are well, and we can pray for people without putting it out there. Pray for brother so-and-so because he had a hip replacement. He may not want anybody to know that. We're just praying for brother so-and-so who may be experiencing some health challenges. Yes, ma'am.
We don't arbitrarily put
Thank
in
you.
names and addresses. When any of our members go into the hospital, or if they've been in the hospital and are returning home, they contact the church office. The church office asks if they wish to have that information published. So it's not put in, by osmosis. I don't know what happens in other congregations.
And that's good that your congregation is doing that, and there may be some others that are doing that. Just another example, just the other day, I was researching the congregation and came up their Sunday bulletin. And in their Sunday bulletin, they had people who were sick and shut in with their name, their full address, and telephone number, and what was going on. And I know we want to be a part of the technological age, but it's a way that we need to do that to protect one another. And I just wanted to highlight that for us. But our goal is to work in concert to take care of our communities together. Yes?
That sometimes a visitor will be visiting someone, and the someone says, "Please don't tell Pastor this." So the visitor gets back to the church, and the pastor says, "So what's up with Sally?" And the person is like, "Well, what am I supposed to do? I got to listen to my pastor, but this person told me not to do it."
Right. That is a very tough situation because we believe in the leadership of our set house, right? And we want to do the right thing. But we have to respect that individual's privacy and their request. Working in LifeBridge Health from Sinai Northwest and Curl and Levendale, before being in this position, I was a staff chaplain. And I see people all the time in the hospital from the faith community. And I cannot go back to my said convention or community and say so-and-so is in the hospital, so-and-so and so-and-so. I cannot do it because it's against HIPAA. I go visit, I provide them services. Do I hang around a little longer? Sure I do. But I go and provide them. And what happens, and Pam's going to get into this, and what happens at LifeBridge Health stays at LifeBridge Health. Case, one example, a member from another church, and her pastor and I are good friends. She was at the hospital and had an operation, and she was on my list to go see. And I saw her, I went to go see her. And when I walked in, she was surprised. And she said, "What you doing here?" She didn't know I worked for the organization. She said, "Oh, I guess my pastor gonna know now." And I said, "Not unless you tell him." And I've gained her respect because when she went back to her faith community, he did not know. And she came back and said, wow, you really kept your word. Yeah, I'm bound by an oath. Confidentiality. That's big to me. Then does it make it heavy for me to carry a lot of stuff? Yes. But we have to respect one another. But Scripture tells us that we are to carry one another's burdens, right? Not blabber them, not send them out all over the world, right? But carry them and pray for one another. Pam, you better come.
I hear a sermon coming on. It is hard to keep HIPAA. I'm an ER nurse. It's very difficult. You're taking care of somebody that you know, and you can't tell others. You take it home with you. It's hard. I've always been, my practice has always been, do I have your permission? They'll say, tell so-and-so, do I have your permission? Can we make that call? And I give them the phone, but sometimes they're unable to. So with their permission, I will make that call for them to get their pastor. But you're all here, you all know that many times the pastor is the last person to know that anybody's been in the hospital. So let's talk a little bit about the confidentiality do's and don'ts. So common sense, to be sure to knock before entering the patient's room. Great practice, never know if there's doing something that they just don't want anybody barging in on. Do dispose of any confidentiality materials that you might have. We all have cheat sheets. Rip it up in 1,000 pieces, put it in your fire. Just make sure that you keep those little cheat sheets close by. If you have a desk, even in your own home, and you have a list of something that belongs to the congregation, turn it over, cover it, put it in a drawer, in a file, and respect the privacy and dignity of our patients. Yeah.
I guess I'm wondering about the legal relationship between the congregations and LifeBridge. Are we considered LifeBridge volunteers, or are we congregations who are collaborating with LifeBridge? And what I'm getting to is that HIPAA is good ethics for congregations, but not the law. As a volunteer for LifeBridge Health, we would be bound by law. So I'm just wondering what additional responsibility we would be taking on participating in this program.
Stephanie, or Suzanne?
I think the best practice is, as you're working with LifeBridge, you have to obey or operate under the same guidelines that LifeBridge operates under. We're encouraging everyone who's a part of this training today to also go back and talk with their faith leaders and their health ministry leads or visitation ministry leads to talk about what that standard protocol is and within the congregation as well. By signing the MOU, it would be a part of the Maryland Faith Community Health Network, which is a pilot with LifeBridge Health, if that helps clarify kind of
The confidentiality statement that you signed today, if you haven't, we need you to sign that today. Just so we have that on record, because we're going to keep a record of that as well. Each time a parishioner comes into the hospital and they're a patient, one of us will go to them and say, do you want us to call your liaison? Each time. So when the congregant joins in your congregation, it's not carte blanche. So each time that they come into the hospital, whether the emergency department or admitted into the hospital, one of us or our representatives will go to that bedside and ask for permission again. We want to have that piece of paper from them once they sign it from the congregation, but if we don't have a paper, we can have a paper to hand to them to have signed. That way it gives us permission to reach out to the church or the congregation and gives us permission to talk to those people. Yeah.
Sorry, please.
So it's interesting that you said you would have that verbal conversation with the congregant, but will you also, in your admission package of consents to treat, will you include a consent for that conversation so it's documented that they gave permission for that to happen?
Yes, because we have two different systems. We have Cerner and your system.
We have Paragon.
And what we would do is, in the chart, we will chart in there that we spoke with patient A, patient, and she gave us consent to call the liaison. Now, when we call the liaison, we will only be speaking directly to them. We will not be leaving voicemails to say so-and-so is in the hospital, because we don't know who else lives with you or who else is going to be answering the voicemail.
And you'll
Absolutely,
Call, and you'll call us back. Right.
With our contact information.
Hi, this is Pam from Carroll Hospital. If Susan's there, please give me a call at so-and-so.
And
So-
best times to call.
Yeah. So it's that. And remember, this is a work in progress.
Yeah.
So we're working together, but we're working separately because we have two different operating systems. So we are working together, and we're going to continue to change things for us. Because it's hard for us to see.
Is there any way to track if you have asked a patient and they've denied it? Is there any way to track that so you can kind of get a handle on?
I will, because currently I'm a navigator, so I have an advantage over poor Dominic, because I already have a database, and so I've added it to my database. So I'll be able to type in today's date, time, patient declined, Faith Community Health Network at this time.
Now, will that be shared with the?
My coworkers.
Okay, but
That
what about?
database is strictly for me and my coworkers.
But there's no way then that, say, my church, Deer Park, would get that information back, knowing that this person was offered but denied it. So we know in our church.
If
is
we
this
don't
successful?
contact you, then you know that we aren't
Right.
able to. Does
'Cause
that make sense?
Because if we call you to tell you your person declined, we've told you they're there.
Right,
And then we're breaking HIPAA.
right.
Oh.
So that would be it. So if Dominic is the person who's sick, and I'm the navigator, and you're the church, I'm not calling you to tell you that he's there, because he says, no way, I don't want anybody to know this.
But is there any way that you could? Okay, there's.
If you don't hear from us, you're going to hear from your other people.
Yeah.
And when your peeps come to you, then you know they've been declined. It's not that we're falling behind on our job. It's like I said, and this is all going to be growing and learning. And in the future, you'll have an opportunity to gather, and we'll be able to maybe add on to this.
Yes,
Lots of
ma'am.
hands.
Going back to the church and the congregation, we have a list that comes out with people that are shut-ins for our congregants that are at home sick, or they're shut in nursing homes and all. And we do have their addresses and phone numbers for people to call them or send a card saying that we're praying for you or thinking about you.
Have their permission.
We do have their permission to do that. So that's still okay to do.
Absolutely.
If the patient
If
has
the
given
patient-
you permission
Right, yes, they
to
are.
give their address and their phone number,
But we
then
shouldn't
you
s-
may do that. But just because I belong to your church and
Right.
I'm in the hospital,
Right.
you cannot put my name and my information in your bulletin because you have not asked me.
Exactly. Right.
And go.
And let me say this. What is best for your congregation, you do what's best for your congregation. LifeBridge Health is not in the business of running congregations
do.
and your operations. So whatever you do for your house, meaning congregation, you do what works best for you. We were just giving some examples of how that HIPAA could be breached.
And
But
this
it really
gives
help-
you knowledge. This gives you knowledge to take back to your churches
Right.
to help you maybe tweak what you do now.
But please don't tell your pastor, Reverend Smith said we can't do X, Y, and Z, because Reverend Smith is not saying that.
Now, it really does help our congregants because people, they want people to care about them,
Absolutely.
and that's part of this. But
So
we
if you
def-
ask me and you've gotten my permission, then
Mm-hmm.
that's fine. But it does set us up for trouble, and it
Right.
opens up a lot of worms.
yeah, I'm sure it
Opens
does.
up a lot of worms.
Thank you.
Gentlemen, yes.
I got a question about the logistics of this. In the healthcare ministry at St. John's, we have at least one person and sometimes three people going to the hospital each day at one time. We get a list in the morning of 20 to 40 people on the list. Are you guys what is the sense in calling us? My question is are you going to screen that list? Because what we do, any Catholics in the hospital, we will go see automatically.
Catholic
St.
in
John.
Westminster.
Yes, ma'am. How are
Not
you
going
going
to
to
change
handle?
your practice.
That's
And
what I
we'll
wanted to
talk
know.
about how we're going to work this out. We're not changing your practice. We're adding to it. We'll give you more peeps. Where's his name?
I see a lot of people.
These are all good questions.
I have a question because when you are become the liaison of your church ministry, a lot of times in the field that I'm in anyway, as nursing, private duty, you have the family coming to you asking you questions. Can we tell the families what is going on with them?
If the patient / congregant has not given you explicit permission to share that information. Oh, okay.
I'm sorry.
Go ahead.
I was asking from being in private duty nursing for multiple years, if the family comes to you as the health liaison, come to you and ask you about the patient, do we have the right to tell them? Because a lot of times the patient would say, "Don't tell my daughter," but then turn around and tell you not to tell her. So where do the lines stand between that?
Sure, this is the line, and we want to be very clear about it. If the congregant, who is the patient or the person who's trying to heal from a sickness, if they have not identified or designated that particular daughter or family member to be their spokesperson and or to receive information about them, you cannot tell them. I know it's difficult because you may have been friends with that person for a long time, but we cannot break HIPAA and share that information. It is up to the congregant to decide who they want to tell, when they want to tell, and how they choose to tell that individual or individuals. Yes, ma'am. Another question, young lady here.
Gets sticky. I'm just thinking, all right, so if I get a call from a member of our group who signed the form and I'm the liaison, and then that person has needs for different things, so I want to put out a request to members of our group to say that there are needs, but I can't say who the needs are for, and then if some of our members go and start bringing meals, they also have to be in HIPAA and can't tell other people. I don't know.
No. I'm sorry, that's a good question
Yeah.
that you raised. I'm sorry, I'm thinking and talking. No. So in the church, we worked in the congregation, I'm sorry, and I'm not trying to be disrespectful. My background is I'm a Christian minister, and so when I think about church, but in the congregation, we work together to carry out the message of God. And so we have, when you have a person who's in the hospital and they come home, you're the liaison, we fill out the at-home plan, and they need meals or whatever. Some congregations have ministries, culinary ministries, or sick and shut-in ministry, or minister visitation, or stuff like that, that helps to carry these things out. So you meet with them, and when you meet with them or tell the information, you just say, I'm sharing this with you so that we can help this patient, this congregant, but please don't go and share it all over the congregation. When we talk to people, I think sincerely, and tell them we're trying to be about a good work, not to tear someone down. But then we've also asked the congregant who's been in the hospital, do you want us to get you help from members of the church? And if they say yes, then you have to talk to the people from your congregation to help them meet those needs.
I think when you see our at-home plan, that will help you, because if
Yeah.
certain things are checked off, then you will see what needs that person's gonna have, and you have obtained that person's permission, because they gave us permission to call you. So that
Right.
frees you up. It's just good practice not to put it out as a blast email to everybody in your congregation.
Yeah.
But just the people who need to know, or if you need a meal, to ask for that meal. But you have that person's permission because they've already given us the verbal, and we figured out an at-home plan.
Okay, I just wanted to, you may not want to say
Does
this.
that help answer
It
your
does,
question?
and I just want to say this now while I have this, and maybe you'll talk about it later. I hear about the at-home thing. I really want to know what kind of assistance, if any, we can give people in the hospital. That's my greatest request, to have some navigational ability for people in the
So
hospital.
you want to know what you're going to do as a liaison at the hospital.
And yeah, that's.
You may not even get to the hospital to see the person, because the people are in and out so quickly. It might just be a matter of me calling you, giving you a heads up that a person is there, and that person may be leaving quickly, so together you and I will work out with the patient, of course, the plan that you're going to need to put into
Okay,
place.
I'm working with a senior population who breaks hips, and they're not in and out.
Because
in a
remember,
day.
our
They're-
goal was not to keep people in the hospital any longer.
No, but I'm
Our-
talking about people that do stay in the hospital and
Correct.
needing that support and navigation in the hospital when there isn't family around.
So it might just be, I might say, they're just going to need a visit right now. And then when I know what their discharge plan is going to be, then we'll be able to complete that at-home plan. But as staff, we always prepare for discharge at the time they're admitted. And that time depends on what's wrong with the patient. So I can't make a plan at the very beginning, because they might be there for a couple of days and things change.
Okay.
Does that help?
Thank you.
Okay.
I wanted to know, will this also impact in outpatient, in mental health? I work in outpatient mental health now. Well, will this also go to the psych unit like at Sinai Hospital? Will that be a piece of it or not?
Okay, so this is a pilot,
I know.
and we're just going to start.
Got you. So it's more on the medical side.
Amen.
All right.
Good question, though. Good answer.
So I'm listening to this with two different hats.
There you are.
Oh, okay.
I used to
couldn't
work
see her.
in the cancer center at the University of Maryland Hospital, and I'm also part of the Shlemut team at Congregation Beth Israel. The whole bottom line is permission. I mean, if you don't get anything out of this, it's, do you have that patient's or congregant or church member's permission to talk to anybody, to say anything to anybody, to get help on behalf of them? We sign these agreements as staff members not to share information even before HIPAA, okay? And it was discovered after HIPAA that one of the things that happened that people didn't realize is that staff members were talking to other staff members, and not knowingly they would say something in the elevator. And it came about that it came to enough people's attention that that was a big issue. Unless you're in a private place, professionally, don't talk about anybody. In our synagogue, we have what we call a mishaberach list, so that a person's name is read out at a certain point in the service, and we say a prayer for healing and strength. There are people that don't want everybody to know that they're sick or in the hospital, and the way they get around it is they'll put their Hebrew name, have their Hebrew name read out, which is usually different than their English name. But of course, not everybody has that advantage. Most of the time in our situation, the congregant is upset if the rabbi doesn't know that they're ill. So in our practice, okay, I still ask, just like you said, can I tell, Rabbi Goldstein what you told me? And so the bottom line with all of this is permission, 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 permission.
Thank you. Thank you. She's absolutely right. Permission, permission, permission. I think there's a young lady behind us.
I just need to be clear about this. If we sign up as a church, okay, then a congregant goes in and they're unconscious. Is every member of the church asked the question when they come in? Or do the members, let's say 20 people decide, yes, they want to be a part of this, that I saw the card up there. Did they sign that and they carry it with them and you find out that way? Does every member of our church get asked? Do they have to be signed if they're unconscious? I mean, how do you get to know what individual needs to be asked?
Well, at the congregational level, you, the liaison, is going to gather that. You're going to offer this program to all of your congregants.
Right.
Domanic may say yes, I may say no. So he will sign, he'll fill out the paperwork, and he will give that to you, and it will get funneled back to us. Okay?
So you're going to have a computer list of each congregation here that is a member of this program.
We're going to know each congregation that has signed the memorandum of understanding, we have that paperwork. So that's the church itself, the congregation.
The church itself, right?
We have a paper that they want to participate or they're interested in this program.
Right.
Then you, the liaison, has signed out some paperwork today, and if you haven't, please do. Fill out that paperwork, and then you're going to take this program back to your congregation, and you're going to promote it to your congregants,
Right.
and they have a choice whether they want to participate or they don't want to participate. If they want to participate, that's fantastic. You're going to have them fill out the paperwork, and you'll get that to us. If they say, no, I don't want to, because they want to kind of see what's going on here and see what happens, that's fine too. At any time, they can join up. There's not like a time frame.
So you're going to have a list.
So we're going to have
So
a
if
list.
Susie
We're going to have
signed
the
up-
we're going to have a copy of that list, and each one of us are going to take it to our office. We're going to keep a copy and/or in the computer for us, and we'll be able to refer back to that. But when we go, so you use the patient that's unconscious. How are we identifying the patients that are coming to the hospital?
Yes.
Sounds like that's your main question.
Absolutely.
Each one of us have different ways because we don't have the same computer system in the same way. Does that make sense? He has a program called Cerna. I have a program called Paragon. They don't talk to each other. So each one of us are identifying our patients a little bit differently at each institution.
Yeah, but we're working in concert to present the program well. So for Sinai and Northwest, you have the card. The card would be signed, coming through emergency, or once you get registered on the floor. And if you're conscious, you will say to the person,
Yeah, I saw the card.
I'm a member of the Maryland Faith Community Health Network. The nurse, while completing her assessment and or through pastoral care, you share that information. They will chart it. I receive reports all day. Even when I'm not in the office, I receive reports to identify who has been admitted to the hospital. And once they have been admitted to the hospital, notified, but we're able to keep track of who's in and who's out of the hospital.
Okay, but this is a pretty big order because in my household, I've been to Carroll, my daughter's been to Carroll, but my mother-in-law's been to Sinai. So do we register the congregants in all three hospitals?
No.
We register one time and we got it from there.
Whatever congregation you belong to is where you're going to sign up.
Okay.
We're going to work on
register-
the other stuff.
Okay,
You
All right.
register one time. If you have to go to the hospital in Curl, we'll still know about it. If you have to go in Randallstown, we'll still know
Okay.
about it. And if you come to Sinai, we are one-stop shop.
and then 6 months later, 4 more people in the congregation say, hey, that's a swell program, I want to become a part of it.
Sign
We
them up.
call you up.
Oh, no.
No, you.
We call you up.
It will work together.
Okay. Okay, I think I got it.
Right.
Yeah.
How you like that, Stephanie?
And if they don't have the card when they show up at the hospital, but they say they're part of the Faith Community Network, that's okay too. We're looking at ways to capture people throughout the process of being admitted into the hospital.
second, sir.
So it's at the front door or through nursing or through the chaplains. We're getting there. Yes, sir.
I think he answered my question, but let me just be sure.
Okay.
Okay.
Let's see if we say the same thing
So there
twice.
is going to be a sign-up sheet that you have in your office, and there will also be a card that the patient has.
Oh, let's clarify that. There is a membership registration form that each congregant, is it in the packet? It's in the
Yes, it's in the
packet. Each congregant will complete the membership, the registration form, membership registration form, and then we'll bill
But will the patient also have a card in their possession?
Yes, that little card that I just moved away from. So when you sign up in your congregation, you will receive a card that I will put behind my insurance card. So when I go to Sinai, I can show them my health insurance card, my driver's license, and my Faith Community Network card. If you don't have the card, we're still going to capture you. Because if you sign the paper, but the liaison hasn't gotten it to us yet, because you had an unexpected, so you signed up today, but he or she hasn't gotten us the paperwork yet, and you come in the hospital and say you're part of that network, we'll take a paper to you and have you sign it. So we're going to get there. So, any other questions? Yes, ma'am.
I just wanted to say, I understand why everybody's so leery, and this is such an important piece of this program. Because if you've been anywhere in healthcare, HIPAA is like the golden rule. If you've been in the federal government, same thing. If you've been in any kind of private network, the Privacy Acts come into play. But I think we're going to be key after this session in explaining to the members back at church, because unfortunately in churches or congregants, we sometimes forget, and we're more flexible with privacy, and unfortunately that could lead to issues down the road. So even if it doesn't even sound right, signatures mean a lot. I like when people talk to each other, but if I don't have it written down, don't give me permission unless I have it written. And if it's not written, it never happened. So we will be key in explaining this to our congregation, our people, our ministers, our reverends, that unfortunately going forth, you have to be one step ahead. And that's why faith and the church and health all comes together.
I do have a question of clarification, though. I mean, it sounds like you are saying that you, and I just need to have this clarified.
Yes, please.
When the congregation joins this, are you going to be asking for the complete membership list of the congregation to enter them in your database?
No.
That sounds like what I've been hearing, and I didn't
So
think it was
if
right.
you come to if you're the liaison at my church, okay, and Domanic is the congregant. So you've opened it up to everybody in your congregation, and Domanic says yes, he's going to fill out the paperwork, and I say I don't want to. That's all. When you offer it up and you introduce this program to your congregation, you will then have a table somewhere. Your congregants will come, sign up for this, and once we have that paper, that's the person that we're going to capture. I can join up at any time, but I don't want to right away because I'm a little hesitant. I want to see how this plays out. So I want to see how good Domanic does first. So it's okay. So that's how it is. Let us go through, I think we had this young lady right here had a question.
I'm not allowed to.
No,
You
you signed for you.
You sign for you. What they have to sign, what's the name of it? It's a member,
It's a memorandum of understanding. For his or her designee.
It's in the packet.
Right. So we're talking about 3 different registration forms here. I think is where some confusion might be. The memorandum of understanding is the church. The faith leader is the one who's signing that one. Then there's you as a liaison. You'll sign that one up. That's for us. And then the member one is the one that you're going to go back and obtain from all your congregants. So what happens at LifeBridge stays at LifeBridge. So you're not going to tell anybody, your friends, your relatives, anything that you see in the hospital as your role as a liaison. Don't share patient information outside of the hospital without the patient's permission. Bottom line. Don't leave sensitive information laying around anywhere, and just don't discuss the patient issues or the congregant issues in public places. Compliance is not voluntary, it is mandatory. For us, any violation of confidentiality, the law, the regulation, the policy, the procedure, or the code of excellence must be reported to the anonymous compliance hotline for LifeBridge Health. So if Domanic and I know we violated something, we have to call this number and report ourselves. We're human. Things happen. But this is a way that we can call and report it to our people at LifeBridge.
Right, but I don't break HIPAA though.
But remember, we're
Neither
all
does Pam.
human. But it is very hard. So this is just information. If you have other questions, we have plenty of time, questions and answers. We can help answer those to you. This is just an overview. So just don't get bogged down. It's really not that hard. We'll help you. Thank you.
Yep, and I think our contact information is on the last slide, and it's in your folder as well. Thanks again.